Do you have severe back pain that is accompanied with pain down the backside of your leg that is severe and stabby and may be associated with pins and needles or burning feeling? Hey everyone, this is Dr. Zach Greenwood here at Performance Sport and Spine. In today's video, we'll be discussing sciatica. We'll talk about what's actually causing your pain, the best exercises, and do you actually need surgery to recover from this condition? So your low back is comprised of 5 bones called vertebrae, L1 through L5, and in between each bone there's a disc. Now at each level there's a little hole where the nerve comes out, and there's a little ball called a nerve root, and that's where this condition happens. And this condition can affect all the lumbar nerve roots, but the L5 and S1, the bottom two, are the most common. What does this condition feel like? Well, for sciatica, there's 2 main criteria. You should have leg pain and back pain, but the leg pain should be more severe than the back pain. Also, leg pain should be sharp, severe, and well-defined. The second criteria is that the leg pain should go past your knee. You may also feel other associated symptoms, such as pins and needles, tingling, the sensation of running water down your leg, or the leg feeling exceptionally hot or cold. So the L4 nerve root commonly presents on the front or the anterior of the leg, and the L5 and the S1 are on the posterior or the back side of the leg. So it's important to note here that there's other structures in your back, such as discs or joints, that can refer pain down the back of your leg, and it's important to differentiate these from sciatica, and we'll talk about this in more detail later in the video. So sciatica is actually an old-fashioned term that covers several conditions. Think of it as an umbrella. So there's radicular pain and the radiculopathy, and we'll break those down now. If you look at our model again, this nerve root can get either inflamed and irritated, i.e. radicular pain, or structures can actually compress the nerve, i.e. radiculopathy. So radicular pain is a chemical irritation by inflammation, and this inflammation breaks down the nerve structures, causing the nerves to fire abnormally. And this is what causes the pain as well as the tingling and the pins and needles. So radiculopathy is compression of that nerve root by mechanical pressure. And this happens when the pressure inside the nerve increases enough that the blood stops. This causes the lack of oxygen to the nerve, and then over time it can cause degeneration of the nerve. And it's important to note that radiculopathy is a loss of function and strength. It doesn't cause the symptoms. Now these two can happen simultaneously, so you can have a loss of function and pain. But it's important to note that the mechanism is a little different for each section. It's likely that you've experienced a mild case of this. Think back to a time when you're sitting in a chair on your foot or laying in bed on your arm. If you're in this position long enough, you may start to feel numbness or tingling. You get up, you move around, and it goes away. This is a good example of what we're talking about. It's important to note that there are other structures that can irritate or compress the nerve root, such as bones, ligaments, or tumors, but discs are by far the most common. So now we'll talk about exercises and self-management. So in the acute phase, this pain can be severe. It can be some of the worst pain people have ever experienced. So it can be psychologically and physically overwhelming. It's very important to rest and not push through it. Secondly, this was not caused by a lack of flexibility or mobility. So you often will experience muscle tightness. This is not a stretching issue. Stretching will irritate the nerve and leave you worse off. So really try to not stretch the tight muscles and just know that this is a symptom of the underlying problem. So sometimes different positions can help. So it's important to try sitting, standing, and maybe brief walking around. Again, these positions should help relieve the pain and focus on the ones that do the most. It may be also helpful to lay on your back with a pillow between your legs or lay on your side with a pillow between your knees. So now we'll go over some exercises to find a directional preference. Can we find a repetitive motion of the spine to help decrease the leg pain? A good one to start with is laying face on the floor with your forearms flat on the floor. Gently press yourself up with your forearms to arch or extend your spine. Does this decrease your leg pain? If so, work on holding it for longer durations. From there, you can do a dynamic version where you kind of use your arms to do a mini press up. Again, only press up to tolerance, and again, this should decrease your leg pain. Another important thing to note is it's better to do it frequent throughout the day than clustered all at one time. Now, often this condition can be so painful that laying on the floor can be really hard and people don't want to do it. So another option is to have a seat, cross your arms, and gently extend your spine. Does this decrease your leg pain? If so, continue to do it throughout the day. If it doesn't, you can explore other options, such as bending to the right, bending to the left, or bending forward. Now with this one especially, be careful, and it should only be done if it decreases your leg pain. If it increases the leg pain, it should not be done. So standing is another option where you can do extension, right lateral flexion, left lateral flexion, or gentle forward bending. But again, only do these if they decrease your leg pain. So another helpful option is nerve glides or sliders. And this has helped to improve disc health for not physically sliding or gliding the nerve. So in a seated position, gently straighten or extend your knee while simultaneously looking up to the ceiling. Only go to tolerance. Once you feel some discomfort, stop, and then bring your heel back as far as you can while simultaneously looking down to the floor. There should be light, mild movement, and it's better to do it a few times to establish a baseline and do it throughout the day. An important thing to note is do not stretch at end range. Don't push your leg as far as you can and then hold it. That's what's going to piss the nerve off. Think of this as dynamic movement, not stretching. Walking is shown to improve disc health, so once you can to pain tolerance, establishing a baseline and then gradually walking more each day can be helpful. Again, breaking up into frequent times throughout the day in short bouts is going to be better than doing it all at once. Fortunately, there's no best exercise for this. And they found that light to moderate exercise is both anti-inflammatory and improves disc health. So you really have a lot of options, and it's more about your pain tolerance and how hard you push than what exactly you do. But again, overall health and exercise will help heal the disc faster. There's also strong evidence that discs can heal. And a couple quick takeaways is the worse the disc herniation is, the faster it heals. And the theory is that it's more severe, the body thinks it's more threatening, so it heals. For instance, this paper found that 66% of all discs healed over 1 year. Now the unfortunate part is it takes months to years, and so this doesn't usually happen fast, but it's important to know that that disc can heal, reabsorb, or adapt without surgery. So there's two theories of why this happens. The first theory is that there's cells and enzymes inside the disc that when they get exposed outside the disc can cause an inflammatory process. And the second theory is that the autoimmune reaction happens when these discs that aren't exposed to the body get exposed, and then the immune system thinks they're foreign, so they try to get rid of them. So now we go in more detail about how to differentiate between referred pain and radicular pain. So referred pain is from those deep somatic structures such as discs, muscles, or joints. And this pain is often achy or diffuse. And the pain is usually worse towards the back and less worse down the leg. If you look at this image right here, this shows you the different referral patterns of just the facet joints. So radicular pain. It's from a single nerve root. The pain is sharp, severe, and well-defined. And the pain is usually worse distally towards the ankle and less bad proximally or towards the back. There's neurodescriptors such as pins and needles, burning or running water feeling. With radiculopathy, there can be loss of strength or sensation. There may be positive neurotension tests such as straight leg raise or slump test. And so we used to think the dermatomes of L4, L5 on the skin were very similar person to person, but it turns out there's a lot of variability. So it's probably more accurate to think L4 does the front part of your leg, the L5 and S1 nerve root does the back side of your leg. Imaging and prognosis. So this is a clinical diagnosis, and imaging is only recommended if symptoms haven't improved after 12 months or if there's sudden or progressive neural deficits or muscle weakness. Now unfortunately, people can have this pain and have no image on their MRI, and that can be very frustrating. But if you look back at this model, that nerve comes out a very small hole, and there's a lot of other structures in there, so other things can irritate it. So don't be too frustrated if you have pain and there's no structure touching your nerve. It's still real, you're not making it up. It's also important to note that the severity and duration of symptoms, radiological findings, and patient characteristics do not consistently predict recovery of pain or function. And most patients improve at 1 year. Spinal injections. There's evidence to support them in the short term for pain reduction, but no difference at long-term follow-ups at 1 to 2 years. And they are a little hit or miss depending on the person administrating it and the technique. It appears they can help with both the inflammatory and the compression aspect, and it's probably better to get them earlier done rather than later. Surgery. There's evidence to say that it helps in short-term pain, but no difference in pain or function at 1 to 2 year follow-ups. It appears that if it's done sooner, before 6 months, it's more successful, and it should always be done when there's the red flags of sudden or progressive muscle weakness. Now, one thing to note here is if you've had the worst pain you've ever imagined for 1 to 2 months, that's going to seem like a really long time. And I've had patients where this truly just kind of breaks you, no matter how tough you are. So even if you're not going to have any difference at 1 to 2 years out, if injections or surgeries can help your quality of life and reduce your pain greatly for 2 months, it's something to consider. So there should always be an option for the more severe acute cases. Drugs or medication. Unfortunately, there's no evidence for gabapentins or oral steroids helping with this condition. And there are the potential long-term effects, so unfortunately, this is not going to be a viable option. So some red flags to be aware of are severe or progressive muscle weakness, any suspicion of cancer or trauma, or Cauda equina syndrome. And this is a large disc pressing on the nerves below the spinal cord. And this is associated with bowel, bladder, or sexual dysfunction, and it's immediate medical referral. So now we're going over a differential diagnosis for people presenting with this kind of pain. So the first is the hip joint. The Fader orthopedic test is helpful, as well as is the patient limping or not. The next joint is the SI joint, and there's a Lancet cluster of 5 tests that can be used, where 3 out of 5 tests positive increases the likelihood. The next one is peripheral artery disease. Now this person is at risk if they're a smoker, the pain is worse with exertion and better with rest, and it's important to examine the feet and check for blood pulses in the feet. Myalgia parasitica. Now this is entrapment of the lateral femoral cutaneous nerve, and it's superficial symptoms of pain and numbness. Now this presents on the front or the anterior lateral thigh, but sometimes can be fused with sciatica. So lumbar stenosis. Now this person has leg pain that's worse with standing or walking and better with sitting. Often they're over the age of 60. There's an exertion test if it's positive at 30 seconds. There's pain in both legs, and those neurotension tests are negative. So deep gluteal syndrome, more commonly known as piriformis syndrome. This can be worse with sitting. There can be persistent hip or buttock pain, and the fair position may reproduce the pain, but it's important to note that this is often overdiagnosed, and it's really important that you've ruled out sciatica confidently before making this diagnosis. Sciatic endometriosis, and this is where the endometrium grows and causes plaques on the nerve. Now with this, the pain is often once a month and very cyclical. If this is the case, hormone therapy and surgery are the options. And then lastly is diabetic neuropathy. The foot and leg should be examined, as well as different blood tests to check for sugar blood content. Thank you so much for watching our video on sciatica. We really hope you found it helpful. If you did, please like our video and subscribe to our channel, and don't forget to watch our other videos.